All right, everybody, we are now on to Unit 6. So we've learned a lot already. We're finally on to our last unit, and so that means three more chapters. So we're going to start with Chapter 18, which is our urinary system. Just like all of our other lectures, I will do my very best to point out the nice to know versus the really need to know stuff that you should key in on. And one thing that's a bit different about this unit for chapter 18 and especially chapter 19 is that we'll finally really start discussing a lot of differences between the male system and the female system. And a lot of our other systems, while there's some slight differences, a majority of our anatomy and physiology is the same across both sexes. So, as I said in chapter 18 and especially chapter 19, where you'll see we have our slides broken up between male and female, I really want you to pay attention to the differences between the two systems. So, let's get into chapter 18. So, our urinary system, sometimes this is also considered the renal system. You may hear that word. Renal is another word for kidney. And the reason for that is our kidneys are really the workhorses of this system. And so, our urinary system as a whole is the major excretory system of the body. So, it's our major system that is going to excrete wastes. So a lot of our wastes are going to be able to be exited from the body via the urinary system, and we'll talk about that process a little later on. So we said the kidneys are the workhorse of this system, but there are some other pieces like the ureters, the urinary bladder, and the urethra that are going to help the kidneys to get that filtrate and urine out of the body. So the interesting thing in a sense about our kidneys is that while we have other organ systems that help us eliminate wastes, an example of that would be the digestive system that we talked about in our last unit, none of those systems are primarily responsible for excretion of waste. So if we got rid of our urinary system, if we got rid of our kidneys, then we would not be able to get enough waste out of our body to compensate for the lack of that major excretory system in our workhorses, the kidneys. So you can live with one kidney. So, for example, if a family member or someone that you match with in terms of blood type is losing function of a kidney or both kidneys, you can donate one of your two kidneys so that they can get a functional one. So you can kind of run on 50% capacity. It's not ideal, but it's definitely doable. But with both of them non-functioning, then you're not able to get enough waste. So we'll talk a little bit more about the clinical side of things as well. But one kind of clinical example that goes with this concept is dialysis. So if you've ever heard of someone that is going through dialysis, it's because the kidneys are not functioning well enough to remove the waste from the body. So the body now needs help to make sure that those wastes are not building up. All right, as always, we start off with our functions of our system, and we just had a big bolded bullet point on our slide above that says that the urinary system is our major excretory system. So no surprise that excretion would be part of that. One of the other things that we don't get super into detail with, but is a very important function of our urinary system, is regulation of blood volume and blood pressure. And those somewhat go hand in hand. So if we have more fluid, if we have more blood, oftentimes our blood pressure is going to go up some. If we're lacking blood volume or we're lacking fluids, blood pressure is typically going to go down. But we'll talk about this a little bit more down the line. Regulation of blood solute concentration. So I need you to think way back to the beginning of class. Our unit 1, we talked about the difference between a solute and a solvent. So remember, solutes, especially in the blood, are things like proteins, sugar in the form of glucose, salt, all those different ions. We've talked about a few systems now that help us regulate pH. For our urinary system, we're referring primarily to the extracellular fluid. So this would be the fluid that is surrounding a lot of our body's different cells. Another thing that we won't go super in depth with, but we'll mention briefly, is regulation of red blood cell synthesis. So there's a hormone within the kidneys that kind of tells us if we need to make more red blood cells. And then we've seen this one in a few different chapters too. Remember, we started in the integumentary system. We've talked about the liver with vitamin D. So the kidneys are another step in that chain to get vitamin D all the way to its active form. We won't go into detail on how this occurs, but it's important to know that if you see this regulation of vitamin D synthesis on your test as one of your options for urinary system functions, that is a function of our kidneys. All right, a little more straightforward than some of our other systems in terms of how many pieces, but make sure we pay attention that we have two kidneys. So we have a right and a left kidney. I was just mentioning to start with that you can function with one, but we have two. We have two ureters. So these ureters are what connect our kidneys to the bladder. And so we have one for each kidney, a right and a left again. We have one urinary bladder, so both ureters empty into the bladder, and we have one urethra. And both the bladder and urethra are two things that we'll discuss later in this chapter that have some differences in anatomy between male and female. All right, here's a good summary slide here. Some of the things on our picture here that are not in bold are not necessarily part of the urinary system. So the liver and spleen are both in the picture, but not in the urinary system. Our adrenal glands can be a tricky one because they sit like little triangles right on top of the kidneys, but yet they're not technically part of the urinary system. They just kind of live on top of our kidneys. We remember those from our endocrine system. The only other things that are not in bold that you should pay attention to is this renal artery and renal vein. So our kidneys are our filtration system. They're trying to filter waste out of the blood. So they need a really good blood supply going into the kidney. And then once that blood has gone through its filters, it has to go back out via that renal vein. So the renal artery is going to supply the kidneys with blood. The renal vein is going to then drain that blood from the kidney to go back towards the heart. And so we see that inferior vena cava that's going to go all the way up to the right atrium. Okay, we have two of them, so we call them bilateral. They're not right next to each other. We have a right and a left. And then the word retroperitoneal means they're in the back portion of our peritoneum, that peritoneal cavity. That's kind of like our abdominal and pelvic cavity. So there's our kidneys right there, inferior to the liver and the spleen. Like I said, you can see our triangles on top. Those are your adrenal glands. So if you ever heard of a kidney bean, it's because our kidneys are bean shaped. They weigh about 5 ounces. So if you picked up a fresh bar of soap, that would kind of give you the same weight as a kidney. Obviously, you guys don't need to know the weight of our kidneys. They're usually located between the 12th thoracic and 3rd lumbar vertebrae. So if you remember from our skeletal system chapter, T12, our 12th thoracic level, is going to be our final level of the thoracic spine, the middle portion. And then our 3rd lumbar vertebrae would be about halfway down our low back. That would be L3. So there can be a little variation between individuals, but they're usually located within that space. One other thing that's kind of a fun fact, but you don't necessarily have to know it, is that our right kidney is slightly lower than our left. If you look at our liver, it kind of is half of a rectangle. It's kind of like a right triangle flipped on its side. So this portion of our liver on the right side is much larger than the portion of our liver on the left side. So our right kidney has to bump down to make space where the left one can sit a bit higher. Okay, we're going to talk about the structure of the kidney a little bit. We're going to go into a little bit of detail, partly because our kidney is really our workhorse or the motor of our urinary system. Our kidney is what's doing all of the filtering and deciding what's going to stay or leave the filtrate, which will eventually become urine. So, like usual, there's a lot of labels on everything. Make sure you're really paying attention to the stuff that we talk a little more about. If we don't talk about it in terms of adding some bullet points or my words and kind of telling you it's important, then it's probably more of a nice to know. So, the first thing talk about is the renal capsule, and it does exactly what it sounds like. It surrounds the kidney. And it's just connective tissue. It's protection. It acts as a barrier, and just like other connective tissue, it also is able to kind of stabilize the kidney and kind of hold it in space. This word hilum we saw with the lungs as well, and it's this little indentation where we're going to have our renal artery and vein. We're going to have some nerves that travel into that area as well. And this is also where our ureter is going to kind of enter and exit the kidney. Okay, our next few terms, the renal sinus. And so that contains the renal pelvis, which we'll talk about in just a second. It's also where a majority of our larger blood vessels are, and some of our fat deposits within the kidney will sit and kind of concentrate at the renal sinus. So you can see we still have some of these larger artery and vein, or arterioles and venules they're becoming. And you'll see eventually they spread all the way out into this cortex of the kidney that we'll mention. The next thing that you definitely need to know are the calyces. And so we'll talk about a structure called the nephron, and we'll kind of go through the pathway that urine travels before it gets to the bladder. But our calyces are these areas that are beginning to increase in size. So this is a calyx, this is a calyx. So we have both minor and major calyces. The minor ones are a bit smaller and join to form major ones. So this would be your calyx, this darker yellow, and you'll see they'll start to collect and feed into the renal pelvis. So the renal pelvis is the space that is going to eventually contain urine, and it narrows. So this big area would be our renal pelvis, and it's going to lead down to this ureter. So our minor calyces form major calyces, which feed the renal pelvis area, which will form the ureter. All right, we're still sticking with our kidney structures. So the cortex is this outer portion. This is our cortex. And then we have the medulla is the middle. So think M for middle, M for medulla. So cortex is outer, medulla is the inner. The renal pyramid is kind of a cone shape. I know it looks more like a circle here, but really it's kind of a cone. And so what our renal pyramid is a structure that has a base that extends into our cortex. In a sense, it's our medulla's connection to the cortex. So it starts in the middle, in the medulla, and expands out to the cortex where our nephrons are located or starting. And then we also will mention the renal papillae. And so this is the tip of our renal pyramid, and it's kind of what's connecting the renal pyramid to that minor and eventually major calyx. So just to point out, just so it's not confusing to you guys, calyx right here, the word that I'm circling with my cursor, that's one calyx, but we have multiple calyces. So it's a little bit of a weird plural one. So here's just kind of a look at a cross section of a cadaver kidney. And you can see, obviously, our image on the left is a little easier to pick out all the different segments. But if you look at the color differences and some of the shapes here, you can still make those connections. So again, we'll talk about the nephrons that are located on the outside, but our renal pyramid starts at the medulla and extends to the cortex. Our papilla is going to be the tip of our pyramid that's going to help drain into our minor and major calyces. They all join at the renal pelvis, which will empty into the ureter. And that ureter we'll talk about down the line here is going to connect our kidney and drain the urine from kidney to bladder. Okay, our nephron. So I've said this word a couple times now. This is what you should know as our functional unit of the kidney. So this is really where urine is being formed. And initially we call it filtrate. So we don't just kind of make urine, we make filtrate that we then term urine once it's fully formed and headed down the ureter to the bladder. So we have millions of nephrons in our kidneys. And so the color difference here is the cortex is this lighter pink. This darker pink is our medulla, so middle towards the outside. So you can see this is a really zoomed in version of what we were looking at previously. And so we have two different types of nephrons, and only about 15% are what we call juxtamedullary. And these two halves are two different things. So this one on our left is the juxtamedullary nephron. And what makes them different is this loop of Henle, one of the pieces that we'll talk about in a second, is going all the way down into the middle versus a majority of our nephrons, what we call cortical nephrons, they barely reach that middle portion. So this goes much farther down. In our juxtamedullary nephrons, these 15%, they're the ones that are doing a majority of the filtrate formation. So they're really our most important nephrons. So this lists the kind of pieces or parts of our nephron, and we're going to go through those one at a time. We're going to talk about a couple different processes involved in urine formation. And so I want you to make sure you're paying attention as I kind of go through these different pieces of the nephron because they all have their own role in our three steps of urine formation. Okay, so our first one is our renal corpuscle. So there's a lot going on here, but I want you to keep it relatively simple. We're going to keep it as these two main pieces, and you just need to know the two main pieces. Don't get too caught up in all these labels. So when you see renal corpuscle, the first word you should think of is filtration. So this is step number one of urine formation is filtration. And so this is the very first portion of our nephron. So if I'm looking at my big picture here, this is my renal corpuscle. And as we were just saying, it consists of two main pieces. The glomerulus is a network of capillaries. So it's almost like a ball of yarn in there. It's a bunch of capillaries, remember our smallest blood vessels, that are twisted around like a ball of yarn. We also have a capsule surrounding those glomerular capillaries, and that's what we call the Bowman's capsule. And so it's surrounding those capillaries to more or less collect the fluid or blood being lost by our capillaries. It's really not blood. At that point, it's really plasma and all the solutes, but that's what is surrounding the capillaries. And it is going to collect that fluid and open and kind of funnel it into the proximal convoluted tubule. That's the next piece we'll talk about. Our Bowman's capsule has these special cells called podocytes, and they kind of help form a barrier around the capillaries so that that fluid can be collected and moved on to the next step. So glomerulus plus Bowman's capsule equals the renal corpuscle. And as I said, you should associate that with filtration. Those capillaries are under a lot of pressure. And so that pressure is pushing that filtrate out of the capillaries, and it's being connected or collected, not necessarily connected, by Bowman's capsule. So our kidneys can kind of control how much blood pressure this glomerulus is under. So if we want to push more filtrate out, we can kind of turn up the pressure because that's what's forcing the fluid out. If we're kind of making too much filtrate and we need to back off, then we can back off of the pressure. And our afferent arteriole, this blood supply here, can open and close, dilate or constrict to allow more blood or less blood to get into those capillaries. We can go really into depth with the kidneys. We're going to keep it bigger picture. but there's a lot of steps and physiology involved in how our kidneys function. Okay, we had a respiratory membrane between our alveoli and the capillaries in our respiratory system. Now we're going to talk about the filtration membrane. And so these are kind of the structures in the corpuscle and how they meet up. So these are our parts of the filtration membrane. So we have the capillary endothelium. Remember, capillaries are just one layer. So even though we call it endothelium, the innermost layer of our arteries and veins, the capillary is just one layer. That makes it easy for stuff to move in and out of them. We have the basement membrane. And so that's kind of our basement layer, our base layer. It's just what's holding everything in place in a sense. It's keeping everything together. We have our podocytes. Those are the special type of cell. They have these kind of projections that help form this membrane. And then we're filtering plasma through the capillary because it's under pressure. And we call that filtrate. So remember, plasma is the fluid portion of the blood with some of the other solutes in it, some of the other things dissolved within the plasma. And so that filtrate is going to contain water. It's going to contain some proteins. It's going to contain some salt, some sugar. There's going to be a lot of things in that filtrate that is going to enter into Bowman's capsule to be funneled to the proximal convoluted tubule. So this is where we were at. So there's our glomerulus, that capillary network. There's our Bowman's capsule surrounding it. And as that filtrate is pushed out, it is going to enter the proximal convoluted tubule. So you'll see we have a proximal convoluted tubule, a PCT. We also have a distal convoluted tubule, a DCT. And one of the things I find that students mix up frequently is thinking that our proximal convoluted tubule comes directly before our distal convoluted tubule. So they don't go right in order. So our proximal tubule, our PCT, is where filtrate is going to enter from our Bowman's capsule. Our renal corpuscle is going to empty into the PCT. The next step is the loop of Henle, also known as the nephron loop. And this has both a descending and ascending limb. So if you remember from our picture above, we kind of went down into the medulla and then it goes and loops back up, called the ascending limb. And so at this point, we have the next process happening, what we call reabsorption. And so initially, we push a lot of filtrate out, and we don't necessarily want to get rid of everything that's in that filtrate. So the first thing our kidneys do is take back a lot of what we got rid of. And when I say a lot, I mean a lot. Like 99% of what is filtered out here and enters the proximal convoluted tubule will actually be reabsorbed into our bloodstream. And so that happens primarily within our loop of Henle, and we'll talk about that a little bit more. So we went from PCT to the descending loop of Henle to the ascending loop of Henle, and now we are at the distal convoluted tubule. And it's kind of our passageway or connecting point between our loop of Henle and our collecting duct. Our collecting duct is what's going to empty into our minor calyces, and it's carrying fluid from that outer cortex, because we went back up our ascending limb, back down into the medulla. And so we're going to have only one collecting duct for multiple nephrons. So each individual nephron does not have its own collecting duct. It's going to collect filtrate from multiple. So this is a really good slide to review. So we kind of went up through these components just now. So that's kind of our 5 components of the nephron itself. If you want to split renal corpuscle into its 2 parts, that's a good way to make sure you remember it's got the glomerulus and the Bowman's capsule. We said the collecting duct is kind of part of the nephron, but we have one duct for multiple nephrons. And then that papilla, we said the tip of the pyramid, that's really where those collecting duct or the collecting duct is going to now empty the filtrate to begin to funnel it towards the ureter. Okay, this slide right here is a nice to know slide. You do not need to spend a lot of time studying, memorizing this flow through the kidney. The main thing or concept that I want you to understand from this slide is that we need this network or this kind of branching of our vascular system all throughout the nephron. Because remember, after we filter out a lot of things, we're going to reabsorb most of that. So we have to be able to reabsorb it back into the bloodstream. We need access all over. And we're also going to continue to secrete more things out of the blood into different parts of the nephron. So not everything in urine is coming from this area. There's some things that are added later down the chain too. But as I said, do not spend your time memorizing this entire pathway. At the very least, make sure you remember that the renal artery is what blood supply is entering, and the renal vein is where it's exiting. The ureter is also there, and all of this enters and exits at the hilum. Okay, so we've mentioned these three steps already. So filtration, that's going to happen at the renal corpuscle. We have that blood, plasma, and other solutes leaving from the glomerulus and entering Bowman space. Remember, we call that filtrate. We don't have urine exiting, it's filtrate. The next step is reabsorption. So make sure you add that RE. It's not tubular absorption, it's tubular reabsorption because we already got these substances into the blood at one point. We then pushed them out into the filtrate, and now we're reabsorbing them back into the bloodstream. Like I said, 99% of that filtrate is going to be reabsorbed. And then finally, we have secretion. And so this is when we still have some substances in our blood that were usually too large to get rid of in step number one. And so now we're going to go through a separate process of putting that into the filtrate that will become urine. So the parts that I want you to associate, the renal corpuscle filtration, that's an easy one. Step 2 and 3 aren't quite as straightforward, but you can think the proximal convoluted tubule, the PCT, and the loop of Henle go with reabsorption. There's a little bit of secretion that happens here, but for the purposes of our class, you can keep PCT and loop of Henle with reabsorption. And then our DCT is going to be with secretion. We don't really put the collecting duct with a job here. That's kind of these three steps are already finalized by the time we are kind of emptying into the collecting duct. That's really just a holding tank before we funnel into a ureter. Okay, so in the renal corpuscle, we'll get a lot of water, some ions like sodium and potassium, and some other smaller molecules that can make it through the filtration membrane. So if things are too big, they're not going to be able to exit that membrane. So about 19%, don't worry about the numbers here, but 19% of plasma, so about 20%, 1/5 of the plasma that makes up our blood is going to become filtrate. That's a lot. So we can't get rid of that much fluid at one time, or we would have some real issues. So only 1% of filtrate is going to become urine. The rest is going to be reabsorbed. So 99% of filtrate is reabsorbed. We just said this only small molecules are going to be able to pass through that membrane. Some proteins that are really small can make it through, but for the most part, anything that's kind of a full protein or bigger is not going to make it through that first membrane. That's why we have this other step here. I mentioned this concept earlier is that filtrate depends on filtration pressure and what we monitor as our GFR. GFR, glomerular filtration rate. That's what we're going to look at for kidney function. Your GFR, glomerular filtration rate. And that glomerular filtration rate, the GFR, is being kind of controlled via the filtration pressure. So as we said, the more pressure there is, the more filtrate that will be formed. And as we force substances out, so there's a few different things going on here. We have that pressure itself pushing fluid out. And then we also get some osmotic pressure and interstitial fluid pressure. We're not going to go into detail, but remember, the body likes to stay balanced. So if we're pushing salt and some small proteins and sugar across the membrane, water is going to want to follow that so that we keep our concentrations balanced. So that's just what this is saying. But again, more of a nice to know. This is what you really need to know. Okay, our next step is reabsorption. So we said 99% is going to be reabsorbed. So this is a very important step, or we would be getting rid of way too much water and nutrients. So we kind of said our PCT and our loop of Henle are responsible for this. So the PCT is the main site. So this is where we're going to pull back our ions, our other solutes, and water that we don't want to get rid of. Like we said, we're getting rid of way more than we actually want to. So the stuff that our body can use and benefit from, we want to take back. This also happens within the loop of Henle, and this in the descending loop, this is where our filtrate's really getting concentrated. So most of the water is getting pulled out. We only have the stuff that we want to get rid of. This whole process is controlled by hormones. And so we kind of kept our hormones in your endocrine system chapter because they belong there as well. But I want to bring up one that we talked about there that's very important, and that would be antidiuretic hormone, ADH. So that's initially made by the hypothalamus. We call it vasopressin, VP, when it's in the hypothalamus. So vasopressin and ADH are the same hormone, just two different places. Our hypothalamus, if you remember, empties that into the posterior pituitary gland, and that's where we term it ADH. So it's antidiuretic hormone. So a diuretic, a medication that's a diuretic, causes increased release of water and increased formation of urine. So if we have anti-diuretic hormone, think to yourselves for a second, what is that going to cause the kidneys to do? Is it going to cause them to make more urine or make less urine? Good. If you said it's going to cause us to make less urine or retain more water, then you are on the right track. So an anti-diuretic is going to promote more reabsorption of water and solutes. Because typically, if solutes are being reabsorbed, then water is going to follow it. And so if we have high levels of ADH, that means we're going to retain more water, pull more in. If we have low levels of ADH, that means we're going to leave more water and solutes within the filtrate. So that's one that I wanted to make sure, even though we don't really get in depth with testing it in this chapter, that you remember exists, because that's the primary hormone that we're talking about. There's some more going on there, but we're not going to get too into the weeds. And then step number 3, secretion. So this is when we're going to remove some other substances from the blood. We said we're going to keep our secretion step responsible. The DCT, the distal convoluted tubule, is going to remain responsible for secretion. We said the PCT and loop of Henle does a little bit of this, and the DCT also does a little bit of reabsorption. But to keep it simple, we're going to keep PCT and loop of Henle with reabsorption. We're going to keep that distal convoluted tubule, our DCT, with secretion. And so some of what is secreted in this step that did not get filtered out initially is going to be some byproducts of metabolism, like bilirubin, like urea, like creatine, or really creatinine. So if we have too high of a concentration of stuff like that, the byproducts of metabolism, as well as this could be an area where we add to our filtrate some byproducts of different medications or drugs that we're taking that are being broken down and we want to get rid of. So he said some of this stuff was not originally filtered out because it was too large. And some of this stuff actually got reabsorbed in step number two. And then we decided actually we have too much of that. We need to get rid of it. And so, just like back in Unit 1, when we talk about our different transport mechanisms, depending on the size, the charge, some different mechanisms of the molecule, we're going to have both active and passive transport that allows us to get everything into the urine that we need to. Okay, we said earlier that we have two total ureters because we have one per kidney. And so they're going to get the urine from the renal pelvis and they're delivering it to the bladder. And so that term peristalsis that we saw in our digestive system also occurs within the ureter. So that we have gravity's help in this case too. Our kidneys are superior to our bladder, but we also have some smooth muscle in those ureters that are going to help encourage the movement of the urine. Our urinary bladder itself is our storage center for the urine, and it can hold up to 1 liter of urine. Of course, genetics determine your size of your bladder. So that's just kind of an average, and you do not need to know that number. Our bladder is really got a pretty thick muscle layer, and we call that muscle the detrusor muscle. It's smooth muscle, so we don't get to control it. We'll talk about the reflex of urination here soon, but it's going to help us contract to get urine out of the bladder. Our trigone is this triangle shaped area, and it's because if you connect the dots of the openings of the two ureters and the opening of the urethra, you can make a triangle. So that's called the trigone. I also want to point out that remember from, again, we're looking way back, when we looked at the different types of epithelial tissue, transitional was one of our ones that was kind of an outlier. So it looks like cubes when it's empty and they flatten out into more like squamous shaped cells when our bladder is filled. But it's just a reminder that our bladder has the ability and needs to have the ability to expand when we have a lot of urine in it and then contract back down to a smaller size when it's empty. Okay, I mentioned in the very beginning that we were going to point out some differences in the male and female system. And one thing to point out is that we have this prostate gland in the male system. And so that's one difference that we'll see. The bladder here is located anterior towards the front of the rectum in males. In females, we have the rectum, but directly anterior is going to be the vagina. And then we're going to get the urinary bladder that is anterior to the vagina, and it's going to be inferior to the uterus. And so that's one of the reasons why when women are pregnant, they tend to have less of an ability to hold their bladder because they're having pressure from that embryo or fetus growing in the uterus that's directly above that urinary bladder. All right, so we have one urinary bladder and we have one urethra, and that's going to exit the bladder and carry urine to the outside of the body. So this is another area where we have both an internal and an external sphincter. So our internal urethral sphincter is smooth muscle. That's involuntary. I for internal, I for involuntary. And it surrounds our urethra at the junction here. So this is where our internal urethral sphincter would be. So it's going to prevent urine from even leaving the bladder to enter the urethra. Our external urethral sphincter is skeletal muscle, and it's going to surround it near the pelvic floor. And it's how we can actually voluntarily start and stop the flow of the urine out of the urethra. So if we think about contracting that, it'll close off the urethral flow. If we let that external urethral sphincter relax, urine is going to flow out of the urethra. All right, another area where we'll highlight the differences here. In males, the urethra is much longer because our bladder is up here. It has to travel through the prostate. We call that the prostatic region. So, another kind of clinical thing to point out, one thing that is relatively common as men get older, I'm talking kind of into their 40s, really 50s, 60s sometimes, the prostate can become enlarged. And we'll talk about this again in chapter 19. But the urethra has to travel through the prostate. So, if that prostate gland enlarges, that means there's less space for this urethra, and that can lead to some issues with urine flow. We have the external urethral opening or external urethral orifice is all the way at the end here. And so we have the prostatic region, we have the spongy region, and then we have, the membranous region, and then we have the spongy or penile region of the urethra, which is going to be the longest portion. So in the male system, not only does our urethra carry urine from the bladder to the external environment, but it's also going to carry sperm. We'll talk about this more in the reproductive chapter next, but this cannot happen simultaneously. So sperm and urine will not enter the urethra at the same time. So for the males, that urethra can be 8 to 9 inches long. In females, it's usually only going to be between 1 and 2, about an inch and a half. So it's much closer to the external environment, or the bladder itself is much closer to the external environment than in the male system. So that unfortunately means that females are going to be more likely to get a UTI because the urethra and bladder are closer to the external environment where we have microorganisms and things that we don't want entering the body. One other thing that's, I think, clinically important to point out is UTIs, when they're treated and recognized early, not a big deal. They're very treatable, very uncomfortable, but very treatable. But keep in mind that this urinary system is really one kind of open loop. So it starts with the kidneys and the nephrons, but then everything ends up connecting down all the way through the urethra. So if we get a UTI that starts in the urethra and it kind of spreads up to the bladder, if it goes untreated, it can then travel up the ureters and actually infect the kidneys as well. All right, guys, last thing for our urinary system. So, first of all, micturition is the term for actually voiding the bladder, for urination. So, the micturition reflex is our reflex that allows bladder emptying. And so, it's activated by the stretch of our bladder wall. So, once your bladder stretches to a certain point, you're going to get action potentials, nerve signals that actually travel to the spinal cord. So back when we talked about our autonomic nervous system, we mentioned the sympathetic system, which was fight or flight, and we mentioned the parasympathetic system, which we call rest and digest. So part of that rest and digest is allowing our excretory systems to function. And so we get parasympathetic action potentials that cause contraction of that detrusor, the smooth muscle, and our internal urethral sphincter is going to relax to allow urine to enter the urethra. So that initial part of the reflex, this aspect, all of this happens just between the bladder and the spinal cord. So that initial emptying happens via the spinal cord. The sensation of needing to urinate is the only part of this reflex that goes through the brain. So this initial kind of parasympathetic action potential, bladder pushes urine out, internal urethral sphincter relaxes to allow urine to enter the urethra. That all happens without us even thinking or being conscious of it. But at the same time, we get this signal that we need to urinate. So the functional aspect travels just between bladder and spinal cord, but that urge or the sensation is what's going on in the brain. So really, even without our brains, that reflex can function. All right, guys, I will see you in chapter 19. If you're looking ahead, keep in mind that chapter 19 has two different slide decks. So we have an introduction in male system and then a female system. So make sure you're taking a look at both of those and really keeping track of the differences. Have a good day.